All right, well, let's go ahead and get started. Thanks, y'all, for joining us for our Families and Health Special Interest Group webinar for September. Today, we've got Dr. Melissa Welch joining us to talk about single session therapy from a family-centered lens. So, Dr. Welch is a licensed marriage and family therapist. She's the Associate Program Director of the Florida State University Family Medicine Residency Program at Ascension Sacred Heart Emerald Coast in Walton County, Florida. Her academic and clinical work centers on the integration of family systems principles into healthcare, and her research has focused on advancing family centered care, identifying opportunities to enhance family engagement in the primary care setting. So she'll be great to learn from this hour. She brings a relational, biopsychosocial, spiritual lens to her work in medical education, where she supports residents developing the behavioral and communication skills essential for whole person care, which we all aim for. So, Dr. Welch, I'll pass it to you.
Thank you so much, Angela. I'm really excited to do this, and I just want to say thank you all for giving me the opportunity to do it. And I just feel like I always need to say this anytime I present. I get really excited when I talk about family-centered care, and I kind of nerd out and geek out a little bit because I am so passionate about it. So I try to pace myself while I'm going through this, but if I get really excited and I start zooming through it, feel free to try and slow me down with comments or questions in the chat box and we'll make it more interactive. Also, I'm excited that there's so many people logged on right now. As I was prepping last night with my husband, I told him, I said, we'll be lucky if there's 10 people. No one shows up for these things. And then now all of you are here. So that's really exciting. And I'm glad that y'all are interested in this topic. I had some technical difficulties with the slides, so I'm going to try my very best to share that now with my phone. And if you see me looking back and forth, just know it's because I've got multiple screens set up here. So I want to share. We're going to do this and type here, paste. Oh, if it would paste, that would be helpful. Okay, well, now that I've said that, hold on, y'all. My camera's going to switch back and forth. Okay, we want to grab, hang with me for just a second. While I'm getting this, put a 1 in the chat if you are a clinician, because I'm curious how many people are clinicians here. And then put a 2 in the chat if you happen to be someone who's maybe a manager or a director of a clinic. And then put a 3 if you're some kind of like healthcare admin. See a lot of 1s, some 2s. Okay. Okay, good. We can see the slides. This is great. Okay. 1 and 2. Okay, and we have a 3. Fabulous. So that's what I was hoping, is that we would have a mix here today. And I'm going to try to speak about this so that it can relate to each of you, regardless of what your role is. And I also recognize that some people will be watching this later on. So hopefully the information will be helpful to you with whatever your role is currently. So just a quick bit about me. I'm currently working as the Associate Program Director for a Family Medicine Residency Program, and I'm also serving as the lone behavioral health provider in our clinic. And so sometimes I'm doing integrated behavioral health when getting called upon, which I did several times this morning. And sometimes I am seeing patients for traditional psychotherapy. So I think, like a lot of you probably, I wear multiple hats. And so our clinic and I have figured out a way to try and provide single session therapy that works for our patient population. And I just love to include families and engage families whichever way I can. So, oh, turn my video the other way. Oh dear. Turn your video on. I think it may have turned off. It might have turned. Okay, let's try this. Now, can you see me? No,
Not yet.
we're working on it.
There you
Oh,
are.
that helps. Okay. So we wear lots of different hats and you try to make it work for whatever your situation is. So all that being said, I work in a very small clinic. We have 3 to 4 residents providing all the care at once. There are no behavioral health providers here other than myself. So we're kind of just trying to make it work. And I say that because I know some of you are in really large organizations where you have 10 BHCs providing all the care. And so it looks very different. So just keep that in mind as we're walking through this today. Okay. All right. Now that I've talked to you for just a second on this, we're going to try and switch back to that. And we will actually walk through these a bit. Okay. So I want to point out something that probably all of you are aware of already is that there is this huge mental health treatment gap that we're dealing with. And these numbers are from last year, 2024, but we not only have a huge population in the states that are struggling, but we have a growing young adult population and youth population that are struggling more than we've ever seen in the past. And a lot of those individuals, even if there are services available in schools and medical clinics and in the community, private practice, whatever that might be, most of these individuals are still not receiving care that they need in order to improve their overall health, especially their mental health conditions, thinking of things like generalized anxiety and depression, but also substance use. So we know that, right? That's why we got into this field, is to be able to close that gap and provide people the care that they need. And I already asked y'all what role you're in, so I'm sure you're seeing this. So, one of the possible solutions to helping close this gap is single session therapy. And I will say there are other CFHA members who have done fabulous education on single session therapy and given the good background education on what it is. So I'm not going to go super in depth on what it is today. I'm just going to kind of cover the basics. But we need to look at this as an opportunity to reach those people who are who are not having their needs met, because it's unique and it's different from what we've been doing. And when you're doing the same thing over and over and over again, and it's not working and it's not meeting the need of the individuals that we're trying to help, it's time to do something different. And I really believe that single session therapy as a mindset or a framework provides an opportunity to do that, because it is taking that one session at a time kind of approach. And it says, if we have an opportunity to solve something today, let's do it. Or if there's a possibility that we'll see some kind of miracle today, let's make it happen and give it space for that, even if we don't have the opportunity to do a lot more work together. Now, I do want to point out that it does not mean that you only get one session and then you're done and you're cut off. So sometimes I think when people first hear single session therapy, they think, oh, that means you have one meeting and then you don't get any more after that. Not necessarily. So it's just one session at a time. Each session opens up with what is something that we want to achieve. You do the work and then you close with, okay, that felt really good, or this is what we're taking away from it. Do we feel like we need to have more sessions after this, or do you want to call me back when you feel like you need it? There's a lot more flexibility versus what we might do with traditional psychotherapy when we are seeing them week to week or every other week, something like that. So it gives us a lot of flexibility, which is absolutely beautiful in primary care. You can use whatever framework is comfortable to you. I know personally, I use a lot of solution focused therapy, so this feels very natural, but I also use a lot of narrative. And so it's nice that I can weave that into it, and it's not a very, strict, standardized approach to what your session needs to look like. And then it's going to help with lots of different populations. So it's not just going to be for, one size fits all, but you can modify and make it what you need. So we can work with youth, young adults, middle-aged adults, older adults, um, regardless of whether it's a diverse population. I know our clinic serves a lot of Spanish-speaking individuals and families, and so I'm able to do it. I had one today where I'm able to use a translator. So it's nice that there's a lot of flexibility in not just how frequently you're meeting, but also the length of the session as well. And so if you have limited resources like we do in our clinic, it's also nice because you don't have to take up a lot of your time from your schedule. There's just lots of flexibility with single session therapy, which is nice. Put in the chat a um, the letter Y if you're currently using single session therapy in your practice. I probably should have asked that before I gave you all the whole rundown. But just stick it in the chat a Y if you're using it currently. Okay, so a couple of folks, but not very often. Sounds like maybe it's not something that's the regular. But yes, it definitely does fit with the model of care for primary care behavioral health, which is what we primarily use at our clinic. Okay, so some, but not everybody. Well, that's exciting to me because if you're not currently using it either as a clinician or as someone who's a manager or a administrator, I want you to know that this is something that you could implement that would be really helpful. Um, when we do this, we give our patients an opportunity to be treated then and there. And so rather than having them be added to some really long wait list, I know ours is usually anywhere from 3 to 6 months long, where they're just sitting around at home wishing that they had help, it gives an opportunity to meet them either the same day or very soon. It also gives the patient and the patient's family a sense of empowerment to feel respected that when they're coming to you and asking for help, that you're willing to meet them there and join them in that and work together to solve the problem. And it has definitely shown a pattern of effectiveness in the current research. I will say that we need more research to show that this is effective, especially in our integrated care settings. But we do see results that it decreases things like depression, anxiety, and helps with um, phobias and traumas and all kinds of things. Um, Also, I'm working in primary care, and I would think most of you are probably in a primary care setting. Put in the chat if you are in something other than primary care. If you're at a hospital or something like oncology or anything like that, I'm curious. So I previously worked, I guess I should have also mentioned this in my history. Um, okay, pediatrics, private practice. Okay. I previously worked when I was doing my pre-doctoral fellowship at an inpatient rehabilitation center, post-acute inpatient rehab center. It is a mouthful to say, but we were working with individuals who had things like strokes, brain injuries, spinal cord injuries, amputations, things like that. And so when patients were in the hospital and they needed support, we were able to go to them pretty much right away. And when their families needed support, we were able to do that too. So I've been fortunate enough to see this implemented. Across settings. And so I just want you to know, even if you're not in primary care and you're not doing PCBH, there's an opportunity for you to use this approach to care. Oh, Lisa, I didn't realize you were in the Department of Public Health. Ours is too, which is fine. Oh dear. Okay, it looks like the slide got angry somehow, but what you need to know about this, there's some challenges. Sorry, it looks this way. I'll just take my camera off for a second. Stop sharing. Okay. What you need to know about the challenges with single session therapy, because I don't want to make anybody mad. Single session therapy is fabulous. Um, but, or maybe I should say, and with a lot of things that we do in this world of mental health and behavioral health, there are challenges with getting other people to the room. And so when we have just one person in the room, we tend to focus on them and it makes it difficult to bring in other perspectives. And so I think single session therapy, in the way that I've heard it presented, is that it does a good job of exploring the patient's context and asking about what's going on for them in their world and looks at their strengths, including their social support. But sometimes it's missing the true family engagement or what I would call family-centered care component. And I think that's largely due to a lack of training or uh, fear or concern on the therapist's part of not knowing how to do that. And so, what I'm really hoping to focus on today, that you'll take away from this presentation, is that single session therapy is something that you can do. And when you do it, even if you have just one person with you, there are opportunities to make it a family centered practice. And if you want to engage families, there's ways to do that too. And I'm going to share some of those things that I've used in my practice. But there are opportunities to make it truly patient and family centered when you're providing single session. So that's my concern with SST. Nobody get, you know, worried. I'm not dissing them too much. I'm just pointing it out a little bit. Okay, now let's see if we can go back to these slides, if it'll cooperate on the next slide. Oh goodness. Okay, we're gonna have to scroll down a bit. Oh my goodness, y'all. Is anybody personally offended if I just go off of the slides and just talk to you? Anybody? Okay, cool. Thank you for giving me permission to do that. Fabulous. It's probably more natural to me anyways. Okay, so what does it look like? Well, I think the obvious ways to engage family are Can you send out? Yes, Molly, I will try to download them so they are pretty and I will share with you afterwards so you have access to them. I swear they looked really nice last night when I was prepping, and then this morning it just didn't come together, but that's okay. One of the really obvious ways to engage family is when we have situations where it's required, right? So if we have young children or minors and their family members are supposed to be there, or we have an older adult who has a cognitive impairment and they're no longer able to take care of themselves, and so they have a caregiver or someone with them. In those situations, it's blatantly obvious that you have two people in the room. Now, I will say that sometimes, even in those situations, maybe we don't do the best job of getting the feedback from the other family members and we still focus on the individual patient. So when those opportunities to present themselves, it's really exciting to have that. And I would encourage you to be asking questions of the family members or caregivers that are present. And then also, and this makes some people really nervous, but I love it, have them talk to each other. So if somebody says something to you, about the other person in the room, just ask them to look at the other person and have them repeat it back to the other person. And sometimes just getting them to have that conversation in a space where it feels safe because you're with them, that can be healing in and of itself. And remember, with single session therapy, we're not trying to fix everything in the world all in one 30-minute or 1 hour session, but we are looking for an opportunity to make a meaningful change or a meaningful shift that's going to help them when they leave your office that day. So sometimes those conversations, although uncomfortable, can provide a spark that's going to light something bigger and lead to something later once they've left your office. But you're just looking for that little shift. So even just having them engage with each other can be a really nice way to do that. There are other fun things that I love to do with my families that I would encourage you to try. And that could be things like acting out a scene that they had happen at home, or role playing, having them switch, you be mom and you be daughter, things like that. Sometimes I'll have them do sculpting exercises. So I'll ask them, have one family member position the other people in the room into a scene of what it looks like when they're eating dinner or something like that. But giving them an opportunity to move their bodies, to get up out of the chair and do something and show you what it looks like inside their home, outside of your office. And I think those are techniques that we learn when we're training in family therapy, but I don't know. Personally, I got away from it for a while. And when I remembered, hey, I should bring these back into the clinic room, even though it's not typical to see that in primary care, it's been a lot of fun. And my patients and their families have been really receptive to it. So I'd encourage you to try that. And if you haven't ever done those, um, give it a shot and embrace the chaos, because the chaos is where people get, challenged, and you learn a lot in those situations. So everything about primary care, behavioral health can be chaotic at times. So just let this be an extension of that. Okay, the other thing that I want you to do when you are trying to work from a family-centered lens is to watch for the dynamics between the family members, not just what's being said, but how they're saying it, how their body posture is changing. Really watch for those little nuances and then reflect that back to them. And again, your goal here is to provide just a little bit of insight that maybe they're not able to get on their own, and providing them an opportunity to have more awareness of what they're doing or how someone else might be influencing their response so that they can start to make a change. We're we have the assumption, we're holding the assumption with single session therapy that our patients and their families have the tools and resources to be able to make impactful change in their life. And we are acting as not necessarily the expert, but the person who's going to kind of coach and guide them to be able to use those resources to improve their situation. Okay. What? The coach? Oh,
I'm sorry. I didn't realize I
don't.
was on mute. We were just talking about all the delineations between coaching and therapy and all that stuff. So
Yes, and I'll try not to get off on a whole soapbox, but
sorry.
no, it's okay. I'll try not to get off on a whole soapbox with that. But I think the difference is, instead of taking a because I've struggled with this too, right? It's a more active participant role rather than a sitting back and I'm like watching myself do this as I'm talking to y'all. When I'm in therapy mindset, I'm sitting back, I'm listening, I'm reflecting, I'm offering support. When I go into coaching mode, I lean forward a little bit more. I'm giving a little bit more guidance. I'm a little bit more direct. I'm cutting them off when appropriate and in a respectful way to get them back on track. And so I think there's subtle differences, and obviously we're all going to have our own um, definitions of it. But for me, that's kind of what it is. So when I do, and I'll talk more about what my single session therapy program looks like, but when I do mine, I have 30-minute sessions with them. So I'm trying to keep it very on point, on topic, and focused. And so I'm a little bit more active than when we have an hour and we're just a little bit more laid back. So anyways, I'll redirect myself. I'll come back over here. Um, the thing that I want you to take away from anything that you're doing when you have more than one nose, more than one individual in the room, is that we're watching for those little moments and those little opportunities to spark hope or excitement or pride in what they're doing well can be really meaningful and really impactful for them. But they don't have somebody at home who's able to point out when they do that. So even if I'm trying to make this more tangible for y'all. When I have a couple in here and they're frustrated and one of them like gets a smile because the other one said something, and I'll say, I'm making up a name, Joanne, when Mike said that, you started to smile. What was it that's going on for you? And then that gives them an opportunity to reflect to each other and enjoy um, that moment that maybe they wouldn't get to enjoy the same way when Mike didn't get to see it happen or whatever. So that's just an example of that. Okay, so some of the less obvious options when you have one person in the room and you want to engage family more, you can call a family member. So you can say, is it okay if we call your spouse or sibling or best friend to get their insight? Um, I've done this with patients, and I think when I've suggested this, it's because they were mentioning that this other person was really important in their life. And I'm like, well, let's just call them and bring them into the room. They don't have to drive here. And that's worked well. You can also always include someone virtually, like with video. You could get on Zoom or FaceTime is a really easy way to do it. Most people have a smartphone. You could get them on in the room that way. Um, when you have consent from a patient to speak with a family member before the visit, you can certainly do that. Or like with a session I had today, I'm meeting with a father and a daughter, but mom is talked about all the time, but mom doesn't want to come in. So I'm like, can I just call mom? And they gave me her information. So I'm going to try to bring that piece in where I can. Um, so those are ways to bring them in even when they're not physically present. And I think sometimes our hesitance to do that is that it'll take more time. It might take a little bit more time, and you have more voices in the room and more opinions, and you have to listen to that. But what I have found is that that small increase of time that I'm spending with them is exponentially beneficial and allows me to have more information that's going to allow us to be more efficient and more effective. And so even when it feels like, oh, I don't know if I can spend 10 more minutes in here by calling this patient's family member, I would encourage you to at least give it a shot to see if it feels worthwhile to you. Now, there are some other family therapy techniques that we might use to bring a perspective into the room without having somebody actually there. One of the ones that I really enjoy doing is what we call the empty chair technique. And this is when you have an empty chair in the room and you ask the patient to pretend as if that family member was in the room with you and have them turn toward and talk to the chair as if that person was there. And so you are still observing in your behavioral health provider role to provide some helpful feedback or suggestions. You can do that for role playing. You can do that for just needing to get it out, whatever it might be. But the empty chair is a nice way to bring others in. Also, they could be people who are still alive or people who have passed. So don't limit yourself with that. Allow yourself to be creative and try out some different things. Let me know in the comment box, has anybody tried empty chair in your integrated care setting? Put I don't know, a 1 in the box if you have tried empty chair. I'm just curious if anybody else has tried that. I don't see any ones. Okay, I'm going to challenge all of you who are clinicians. Okay, a couple of ones. If you've not, the empty exam table, I love it. If you haven't tried it, definitely try it because it's a really nice way to get some more systems perspective and feedback on what's going on without having them actually there. Do I recommend this as applicable with an interpreter too and cross-cultural? Absolutely. So I would say any of this goes even with an interpreter. The family that I was working with this morning, dad speaks Spanish, daughter speaks English and Spanish, and poor interpreter is on the phone trying so hard to keep up with what we're doing. And he actually did a great job. We use a phone service for interpreting. And so sometimes you get a good one and sometimes you get a not so good one. And sometimes you get disconnected. And that happened to us today too. And you just roll with it. And honestly, my belief is that the work that we're doing with the patients is more about how we are with them than what we're doing exactly. So if we show an example of rolling with challenges as they come up and being kind and respectful and curious, even when there's challenges in the room, those are opportunities to model that regulation and working together, even when it's difficult. And so all of that is therapeutic, your whole way of being with them, and having an interpreter as part of what you're doing can make it more challenging. But I would say, yes, try all of this even with the interpreter. Okay. Okay, some other ways that you can explore family influence and what's going on with the system without the family member there is by doing things like family genograms. Now, for those of you who aren't familiar with a family genogram, I think most of you probably are, but just basically it's a map that shows patterns within a family system where you map up. Usually I'll have people do 3 generations. So me, my children, and then my parents. And then you can look at anything from relationships, health conditions, substance use, causes of death, anything like that. So if there's something that you're working on with your patient and you're wanting to have more awareness of maybe the example that they've seen growing up or what's normal to them, and then being able to help them understand that that's, different for others, or um, to challenge your own biases and beliefs. I think genograms are a really helpful way to do that. You can make genograms as simple or as complex as you would like. So if you want to make it something that only takes 5 minutes and isn't the whole session, fine, and it'll give you some information to work with. If you want to spend the entire session working on a genogram and reflecting back what you're seeing and asking questions, you can do that too. So I really like that genograms are a nice way to bring in that family systems perspective, make it family centered. And there's a lot of flexibility there with how you use that. And then the other thing, I think I already mentioned this, but you can rehearse conversations and role playing with them. So if they know that they're going to have to go home and have a really tough conversation, or say I have a patient who's trying to change. I always think of this poor woman who was trying so hard to eat better, as she defined it, and her adult kids still lived with her, and they brought in like all the snacky things, right? And they had them in the pantry. And she was like, I'm trying so hard, but when it's late at night and I know it's there, it's really hard to resist the temptation. And so we talked about how she could discuss this with the people in her home who were bringing in the snacks that she was trying to avoid, and how to maybe put them in their room or something like that so it wasn't as tempting for her. But she was really nervous about having that conversation because she felt like it was on her. She should have the self-control to not be snacking or whatever. So we practiced that conversation, and so even though no one else was in the room except for the two of us, we were able to bring in those perspectives and practice that systems challenge, that systems piece. So I would encourage y'all to try that too. Okay, I'm going to pause just for a second. Does anybody have questions at this point? Does this sound like something that you can do in your setting? Is it helpful?
I think these are super helpful tips, Melissa. And I'm wondering if you can share some more about the sculpting and maybe examples of ways that you've used that, because that one's a really fun one.
Okay, yes, sculpting. So I actually did this in an exam room. It wasn't even in my office. And I had, oh, it's such a good family case. It was a family who was in the process of fostering some children who, I think it was like three siblings ranging in age from like 6 to 10, something like that. And the kids had been through some really traumatic stuff when they were little. And thankfully, they had been removed from the unsafe situation. And now the foster parents were trying to provide more stability and security, but were really struggling with some different things. I mean, they had challenging stuff like, um, I don't know. They had all the names in the book for oppositional defiance disorder, the ADHD, depression, anxiety, maybe it's bipolar. I mean, they were just like throwing everything at these kids. And mom just seemed so overwhelmed in the room. I think she had a baby with her too, because she was trying to like rock the baby. It belonged to somebody else. It was a whole thing. So the doctor, the physician, left the room for 10 minutes. I don't know, go check on lab work or something like that. And I said, well, let me just stay in here and hang out with y'all until the physician comes back. So I literally had 5, maybe 10 minutes to do something with them. And so I asked them to sculpt a scene of what it looked like when they were hanging out all together. And so with the first little boy, I think I went with the older one first. I asked him to sculpt what it normally looked like. And so I think he moved people around the room. So, like we had a little rolly stool, and we had the chair that you sit on with the paper. And I think I stood kind of along the wall. And so he moved everybody around the room, and they were kind of facing like different directions, except for maybe him and the parent or something were sitting next to each other on the couch, something like that. But he drew a picture for me of what their family looks like currently. Then I asked the younger brother to form them and what he wanted it to look like. What would you want your family to look like when y'all are watching TV or hanging out together or whatever? And so then it was his turn. And this is great to do with kids because they really feel like they're involved and they love that. And they like to kind of tell people what to do. And so they get excited about that part. And so he moved them closer together and they were watching the TV or whatever it was together. And so it was very obvious that there was a difference between what is currently happening with people around the room separate from each other to what they're wanting of closeness. Even with all the challenges that are going on in their home, they still were craving that closeness and they weren't getting that. And I think it was really, we did that and then the nurse or something came in that kind of interrupted it. So it's not like we had a long time to even process it or ask questions or digest it or anything like that. I mean, it was quick. But I think for mom who was so overwhelmed, for her to see that that is what the children want, meaning they're all on the same page and all after the same goal, that felt comforting to her in a way of like, okay, we are doing something right. We are helping them to feel safe. They want to feel close. And that felt good. And you could see that she was enjoying watching them do it and participate in it. So that's an example when you have a lot of people in the room, but you can do it with just, two people in the room. It doesn't have to be a big family ordeal like that. And I think the other nice thing about that example is that it shows that even those little um, short amounts of time that we have with them can still be meaningful and help them to find some hopefulness and encouragement. So hopefully that helps some.
Love that.
Sculpt- Sculpting is a fun one. Okay, anything else? What's your pitch on patience on the why? What's your pitch to patience on the why? Erica, can you tell me more what you mean by that? I'm not sure what you mean, but I will answer that question. Um, Okay, so my other thing that I will say is that yes, we see this with kids a lot because it makes sense. Yes, we see it with older adults because they have to bring an adult child with them sometimes. But I would encourage you, even when you meet with like the regular middle-aged adult, like if I came into your clinic, find a way to include my spouse in my care or invite it, even if it's not going to happen, because I think there's a lot of meaningful information that you can get from that. Okay, let's see. What else was I supposed to have on slides? Talked about that. Okay, let me tell you a little bit about what we're doing at my clinic so that you have kind of an idea of what you could do at yours. So, at our clinic, we are an FQHC that belongs to the health department, and we are one of two FQHCs that are embedded in a health department in the state of Florida. So it's not something that's required. It's something that was done because they wanted a way to be able to serve this community. And so it's nice that our organization really has that heart for helping the community. We have 3 different sites in our county, and our county goes from the top of the Florida Panhandle, like basically South Alabama, all the way down to the Gulf. And so we have a very diverse patient population from the north end of the county that's more underserved and more poor and has less resources, down to the south end of the county where there is a lot of money and a lot of wealth and a lot of access to resources financially. Even then, we still live in a rural area that's underserved. And so we see a whole mix of patients that come in here. Within the county, one of the clinics has 2 behavioral health providers, although one of them told us that the end of September is when she's parting ways with us. So that will be sad when she leaves. So, but we've had 2 providers up there. And then down on the south end where we have the residency clinic, it's just me. And so I have been providing a full day of what we would call traditional psychotherapy sessions one day a week, and the rest of the time I'm available to our residents for integrated behavioral health support, didactics, and things like that. What I was noticing is that when our patients came in, even if I was available to meet with them for an integrated behavioral health visit, if we felt like they wanted another visit, because single session isn't just one session, sometimes you want to follow up, we didn't have a way to do that. We had to put them on the wait list. And like I said, sometimes that was 3 to 6 months long. And it was really frustrating to not have a way built into my schedule to be able to provide that support. At the same time, I like that I have flexibility in my schedule and that I'm available to the residents. And I didn't want to kind of like bog down my schedule with a whole other day of sessions that didn't seem like the answer. And so I creatively, I'm not going to say I went behind anybody's back, but I definitely took some creative liberties to figure out how to do this. I said, okay, I'm going to offer integrated behavioral health follow-up visits, up to 6 of them for 30 minutes each to patients. And I'll meet with them to either provide some interim care until they get off the wait list, or maybe it's something that's more kind of acute and they'll feel like after a session or two, they're good and they don't need any more. And then if that's the case, then we're not bogging down our wait list. And they were like, I don't know about this, Melissa, but sure, if you want to try it out. Okay. So we started it last July 2024, which was when the residents started. And over that time, it didn't like take off to anything big, but we had 24 patients who were seen for an integrated behavioral health warm handoff, who were then scheduled for an IBH follow-up visit. And so I met with more than that for warm handoffs, but not everybody feels like they need one, which is another point for single session therapy. But for the ones who did and were like, yeah, I'd like to see you again, I was able to get them scheduled within 1 to 2 weeks instead of having them wait for months at a time. 9 of those 24 patients no-showed or canceled. So that's 37%, which is kind of high. And 15 patients attended at least one of those follow-up visits. So 62% of them actually showed up for the second visit. Some other fun stats from that. So the most of the patients attended 2 visits so far. So 40% of them attended 2 visits. 33% attended only one. One patient attended 3 visits, 2 patients attended 4 visits, and 1 patient attended 5. But none of them have reached that 6 session max, which I thought was really, really interesting. I really thought for sure that people would get every session that they could and then either transfer over to traditional psychotherapy or go away after that because I told them that's all they could have. And so I was really surprised that this was the case. Most people attended either 1 or 2. And I think that speaks to the fact that sometimes we work with patients who are like, I just need a little support. I need to know that I'm not crazy. I need to know that it's normal for me to be upset at this person for what they did. It's not all in my head. I need to come up with some next steps for how to get back into the workplace or whatever it might be. But they don't necessarily need, every single week for the next 3 years, like some patients who enjoy traditional psychotherapy. So it's just nice to be able to have that option for these patients without bogging down the wait list even more. Of those 15 patients that came to the IBH follow-ups, 10 of them were adults and 5 of them were minors. So the minors came with parents. 2 of them came with a mom and 3 of them came with a dad, which I think is really interesting. And I'm curious, is that common for others to have dad and child come to visit, or is that unique? Because I felt like it was unique that I had 3 sets of dads with daughters or dad with son. That doesn't happen for me in traditional psychotherapy. I don't know what the deal is, but maybe there's something about single session therapy that provides a safer, less touchy-feely therapy vibe that dads feel more welcome to. I don't know. That's just
Hey,
that's
Melissa,
just an observation. Yeah.
did you happen to notice the gender of the child associated with the dad visits?
Yeah, so one was teenage daughter and dad, one was young daughter and dad that I described earlier, and one was elementary son and dad.
Okay. All right. Well, who knows?
Interesting, right?
Yeah.
Like that is so different than what I would normally see in my traditional sessions. And so then for the adults, one of them brought a spouse, and then the rest were individuals. But of those individuals, 6 of them were relational like challenges or relational issues that they were primarily focused on. So I when I went through my list and I was prepping for it, I said, was this one really individual focused? I don't know, but I can find something relational and systemic with every case that I'm on. But I really try to take that focus. But 3 of them really had like something unique and or like individual focus. So I said, okay, fine. 3 of the adults had that. And then I had a mix of Spanish and English. Um, and 40% of all of those that came were bringing a family member with them. So I thought that was pretty cool. I want you to feel empowered to have more than one person in the room when you're doing single session therapy, especially if it is something that you feel like needs to be quick or direct or focused, and you're worried that having other people is going to take things off track. Instead, maybe view it as an opportunity to get more information sooner rather than later and view it as more efficient. Um, but it can be challenging for sure. Okay, what else was I gonna say about our situation? I think it's working well. I think I'm not booked out like crazy, so I can still schedule people for an IBH follow-up within 2 weeks. And sometimes when programs are doing single session therapy templates or whatever, they'll have same day walk-in appointments. That's not something I have, but if someone came in and I was here and available, like I think we could probably make that work. But right now I have them scheduled Mondays or Tuesdays at 11. How many slots a week do you hold in your schedule for these? Yeah, so I hold 2 per week. Mondays at 11 and Tuesdays at 11. So when I get a warm handoff, I will visit with them. We have the visit. And then if it feels like they're wanting more, I will offer this to them as an option. And we can schedule it in the room so that I can follow up with them. And then at the end of those 6 visits, if they get to the 6, which I haven't had that happen yet, and they want to continue on with traditional therapy, then we have them on that wait list so that they can meet with one of the other therapists or continue with me. I have had 2 of the patients that I did this with transfer over to me for traditional therapy that I do on Wednesdays. But yeah, I thought that that would be the outcome for most of these people, that they would wait it out, use all 6, and then be excited to get off the wait list. But for the majority of them, that has not been the case, which I think was interesting. Thinking along the lines of the case you presented on sculpting, could you speak more on addressing trauma using SST, especially considering not wanting to go too deep into trauma if there is not enough time to fully process, perhaps focusing more on emotion regulation skills? Yeah, Gabby. So I think, so just a shout out to Dr. Bauman and Dr. Beachy. They have a whole PCBH snippet playlist series on SST. And one of the things that they've talked about is that, I don't know if we can necessarily treat or attend to everything that goes in to trauma care, but people who have trauma can be seen with SST. And so, again, I think it's more about like a mindset and a way of being, especially trying to focus on in the moment reflection and feedback. The girl that I was visiting with this morning, she was sharing with us about uh, some sexual trauma, and I noticed that she started kind of shaking as she was talking about it, not really becoming emotional necessarily on her face, but her body was showing signs. And so the resident physician and I were in the room visiting with her. And so I just reflected back to her that I noticed that. And, we asked if that was something that she experienced a lot or if she noticed herself doing that. And I think that's the kind of example of being able to just bring it back to in the moment, noticing what's going on with her in her body, how she's responding to this conversation that can provide greater self-awareness and emotion regulation, being able to take some deep breaths to help her kind of regulate and calm back down. But also feeling safe to let her body get out what it needed to get out in that moment. And so, it's not that we needed to go down and ask more questions and get all the details and solve it or, start doing some EMDR or anything like that. But it was just kind of being in the moment with her. So I hope that makes sense. I think it's kind of how we are with any of these cases, regardless of what they're bringing up, of really helping them to feel confident in the skills that they do have, celebrating their successes with them, and pointing them in the direction of where they can continue this work even after that short amount of time with you today. Can you talk about the specificity of just 11 a.m. on Monday or Tuesday impacting or not the interest in follow-ups? Yeah, so I do think that the rigidity of my schedule can make it difficult for some patients, especially if they have work and things like that. And how I've tried to encourage working around that is I'm not suggesting that we do these every week, especially if it's people who are on the wait list. I'm like, let's meet, if I'm doing a warm handoff, let's meet back in 2 to 3 weeks. And then we can do this monthly, or we don't have to, but it's okay if we're just doing these one every now and then. And it does not hurt my feelings if you have to cancel. Please go for it. That's fine. And so that gives them a sense of control over their schedule and flexibility, even if it felt rigid at first. And also, because of kind of my role and being able to go work with residents and do warm handoffs or whatever, I don't care if I get a no call, no show, or if someone doesn't come for one of these, because to me, that means they're either doing okay or they'll reschedule when they need it. And I have other things that I can help with. So it's not like blocking a full day and then feeling like I've wasted my time if they're not showing up, kind of thing. I hope that makes sense. So I set it up that way, thinking that it would provide more access, more days of the week, but not bogging down my schedule so much that it's restricting other things that I can do. But again, I don't think that there's a right way to do this. I think you just figure out what works for your clinic. Who do you have available? What days are they available? And try it out. And if it's not working, try something else. But that's how we've done it. Okay, so also interested in the billing question mentioned by Zoe. Oh, I missed that. Hold on, let me find it. Zoe, where are you? Are you billing for these visits? If so, how and what codes? Thanks. Yes, we are billing for these. Now, I will say our clinic does things strange. I don't know why they do it the way that they've done it, but everything behavioral health in our clinic is billed under the medical provider. And so we are using the codes that go along with that. And I don't have them right in front of me, and they're on the paper that I circle. So I could show you where they are on the paper, but I can't tell you what the actual number is. That's really not helpful. But Zoe, I'm going to write down your name. And when I figure it out, I will email you codes. I'll figure that out. But yes, we are billing for it. And so I bill for them as a 30-minute visit with an established patient compared to when I would normally bill for like a 60-minute visit. And I just realized we only have like 5 more minutes. So let me scan this really quick to see if I have any other questions. Well, there were like 6 more slides we were going to go through, but that's okay. I think the thing that I want you to take away from this, regardless of your role, whether you're a clinician or you're someone who's looking over the schedule and things like that, it does not have to be something that you're offering all the time. It doesn't have to be something where you are completely changing the schedule. It can be worked in little ways, and I think it will provide a helpful tool to your giant toolbox. And the other thing, yes, we'll send the slides and codes. So sorry about that. We'll get that fixed. The other thing is that my two things that I want my residents to take away, and I'll share this with y'all too, is that we want to love on people because they've come to us for care and we have an opportunity to show them love. And we want to be curious and not just what they're doing well and how we can help them, but what we're doing well, what we can do differently. Maybe it's not how it's been done in the past, but there's an opportunity there. So if we're loving on people and we're staying curious about how we're doing things, that means we're going to try things out. And it's okay if it doesn't work, and we don't need to worry about all the productivity stuff. This is a single 30-minute slot once a week or twice a week and just trying it out. And then when it comes to the family-centered part, because single session therapy mindset is great, but when it comes to the family-centered part, don't be afraid to ask those questions. Don't be afraid to invite others into the room. When you find yourself noticing that you are anxious about more than one nose in the room or that it's going to take up more time, remind yourself that your job is to love on them and to be curious. And having that family-centered lens is going to give you a wealth of information. So I know I said a lot. I hope that makes sense. But thank y'all so much for being here, and I'm happy to stick around for questions because I have time for that.
Thank you, Melissa. This was great.
Good deal. Okay, Zoe, I'm getting your email. You would think I have those codes memorized by now, but I do not.
Well, if they're on a paper, it's easy for you to circle. No need to remember them.
Exactly.
Melissa, I'll work with Hannah and see if we can get the list of attendees, and then we can forward out your slides and whatever those codes are.
Sounds good. I don't know why they were so awful. It was so pretty.
They
I
looked
mean,
pretty. I'm sorry.
they were beautiful. I used the new Gamma thing where you tell it everything you want it and then it puts it together for you and it looks fabulous.
I
But
use that.
then somehow it didn't transfer over well.
Thanks, Hannah.
Thank you, Hannah.
All right. Well, thanks, Melissa. This was great.
Thank you so much. Y'all have a good one.
Bye,
See y'all.
Melissa. Thank you.